I have the top of the hour. So good afternoon, and thank you everyone for joining us again for the Superior Health Quality Alliance Roundtable conversation. My name is Jerry Henniker, and I'm joined again today by my colleagues Kelsey Ostergren and Kim Heft. And we are also joined today by our speaker, Lisa Gall, and then also from Superior Health, Julie Campbell. For those of you who have joined us for these meetings before, thank you. We're glad that you come back every week to listen to our presentations and our sessions. And if this is the first time you've joined, thank you. We're glad you're here. We're glad to have you here for these sessions. These sessions are hosted. We're doing them twice a month now. And now in January of 2023, we have a regular schedule starting, and the sessions will be the second and fourth Wednesday of every month. Each session will continue to consist of 30 minutes of education. And this is when we highlight important topics that you've asked us to present on. And also we talk about COVID vaccinations and the boosters and immunizations related to influenza and pneumococcal. This is followed by 30 minutes that we set aside for discussion and question and answer time. And today, during that time, we're also going to follow up on some questions that we received from you at the end of last week's session. So again, we thank you for giving us topics to talk about and also any of your questions that we can help you with. We hope that you're going to continue to join us as we wrap up 2022 and enter 2023 with these twice a month sessions. And as you listen today, think about any pebbles in your shoes or questions that you have that you're just, struggling to figure out. And it doesn't even have to be related to the topic for today. We want to hear about that. And if there's something that, you'd like us to tell you more about or a topic to present on, you can put that in. You can send it to me via chat or just even send it to our team via chat. We appreciate that. Also, continue to use the chat back to today for any of your comments or questions. Again, it can be about today's session or even just other things that you want to learn more about. Toward the end of the session today, we're going to put a link in chat that will link you to an evaluation. From this is where you can give us input on today's session and give us that feedback. We use this feedback to determine our topics for future sessions. And then also if it's helpful, if these sessions are helpful for you, we do want to know about that, of course, but especially we want to know what isn't helpful or what can we improve upon. And then also Kelsey will be putting the link in chat to the PDF for today's slides so that you can have a copy of the slides. So our presenter today is Lisa Gall. She's going to be presenting on care transition resources. And I think we can all agree that those transitions in care for our residents, those who may be returning to your facility from a hospital stay, or maybe it's even a new admit to your facility, those care transitions are really important for their care and to help improve in their outcomes and continue to have a great quality of life. So with that, I'm going to turn it over to Lisa. Lisa, the floor is yours.
Thank you, Jerry, for that introduction. I'm Lisa Gall. By background, I am a nurse practitioner. I started working in quality at the beginning of my career, and about 11 years ago, I joined Stratus Health and work with Superior Health Quality Alliance on lots of things related to healthcare quality and technology. So I'm going to present today on welcome to the Care Transition Resource, Don't Reinvent the Wheel. This was developed by Superior Health Quality Alliance. And some short housekeeping instructions on my end. If you have any questions during the presentation, please enter those in the Q&A box and we'll get to them at the end in a short discussion, as Jerry mentioned. At the objectives for this course, it's a brief webinar to help you discover resources to help you and your facility plan, implement, and improve care coordination as you deal with residents across settings and throughout their lifespans. Secondly, learning how to access tools in the Superior Health Quality Alliance Care Coordination Toolkit. These tools can be modified to meet the needs of your organization or facility. The access tools that have been implemented and tested in various settings, so you don't need to start from scratch. And finally, learn how to begin building and implementing a care coordination plan for your organization or facility. Next slide. So this session will address the how of care coordination. But first, we're going to look at the who, what, why, when, and where. So who needs care coordination? Residents who transition between settings, of course. And what is it? The CMS has defined transitions of care as the movement of a resident or patient from one setting of care to another. Each care provider and setting needs to have the right information to provide the right care at the right time to those we serve. I'll spend a little more time on why care should be coordinated. And I think you all know this, but I'm going to cover that in care coordination provides the best possible outcomes for people we serve. Data shows that care transitions increase the risk of adverse events due to the potential for miscommunication as responsibility is given to new parties. In particular, hospital discharge is a complex process and a time that patients are vulnerable to injury or even death from medical errors. I'm going to take some time here to share some alarming statistics about medication errors, which is one of the medical errors that can occur. The US spends more than $40 billion each year on patients who have been affected by medication errors. The preventable medication errors cost the US more than $21 billion every year across all care settings. And the FDA receives more than 100,000 reports of medication errors every year in the US. Approximately 400,000 drug-related injuries happen in hospitals every year because of medication errors. The main causes of medication errors are clinicians prescribing meds improperly, medications being prepared or dispensed improperly, information about a medication being entered into a computer system improperly, and patients taking a medication improperly. So medication errors are not the only types of errors there are. Other errors can occur at any time, and these are generally errors of omission or commission. The point here is that the safe and effective transfer of responsibility for a resident's medical care relies on effective communication to assure that the resident and their caregiver understands their discharge instructions. So where should care coordination occur? Any setting that provides care and then hands off that care to another setting should provide formal care coordination. Settings such as hospitals, primary and specialty care practices, long-term care facilities, home health, rehabilitation facilities, and other settings such as corrections, schools, group homes, and probably more. So when care coordination should occur at every transition of care. So now we'll look at the how. Before we look at the how, I have one more slide to go over on the why. Next slide, please. So the Impact Act of 2014 was driven by consumer organizations and third-party payers as we move toward a value-based care system, focusing on better outcomes, improved population health, and ultimately lower cost of care. The Impact Act requires collection of and submission of standardized data using common assessment instruments. And you're probably familiar with these, but they do include the long-term care hospital care data set for long-term care hospitals, the minimum data set for skilled nursing facilities, the OASIS or Outcome and Assessment Information Set for home health agencies, and the Inpatient Rehabilitation Facility Patient Assessment Instrument for inpatient rehab facilities. Next slide, please. Stratus Health Quality Alliance developed the Care Transition Model Resource Guide to help facilities and organizations choose from a compendium of resources by care setting, calling out key points so you can review the tools that may meet your facility's needs, along with the needs of your community. Some have identified timelines for implementation of their tools. There are likely hundreds of tools available for coordinating care transitions. And this, of course, is not all inclusive, this compendium. Many healthcare facilities and EHR vendors are building their own. So rather than starting from scratch, you may find tools or processes in this toolkit to help build a care coordination plan in your organization or community. Because after all, it's community coordination that makes the tools most effective. So let's look closer at how to find what you need. Next slide, please. The top of this Superior Health Care Transition Resource page provides an overview of care coordination, which is not shown here, but it is on the website. That's followed by 26 commonly used care transition resources that have been piloted or researched in particular settings. This slide shows 11 of those resources, just as a sample. And across the top, we categorize the settings that they have been implemented in: inpatient and hospital settings, outpatient settings, which includes clinics and ED and urgent care, then skilled nursing facility and long-term care settings, and finally, home care settings. However, even with an X below which one of those tools have been implemented in, these tools can be used or modified to really be used in any setting. Most of them, not all of them. Clicking on any one of these tools on the left-hand side when you go to the website will take you to the bottom of this page with more details of that resource, or you can simply scroll down on the page to see the details of all the tools.
What the hell is this shit? How did you?
Whoops. So you can look at more details of that resource, or you can simply scroll down to see the details of all the tools. From the detailed view, you can access the website that is listed and a sampling of some of the website's tools. Before we go to an example of the detailed view, I want to point out that many tools have similar names, and the name of the tool may or may not accurately describe the content. For example, what's highlighted here first is the Care Transition Care Tool by CMS, which is a completely different tool than the Care Transitions Program Toolkit by Dr. Eric Coleman. And that's different than the third highlighted one, the Care Transition Toolkit from the Patients for Performance Toolkit implemented in Washington and Alaska. So even though they're named the same, they have different content, or similarly, they have different content. Next slide, please. So if you click on one of those tools, let's say we clicked on the Care tool, the detailed view can be accessed by scrolling down on the page or clicking on the resource. This slide shows the CMS CARES assessment tools recommended by CMS as a patient transitions between provider types and settings. This demonstration provided standardized information on patient health and functional status, independent of the site of the care, and it examined resources and outcomes associated with treatment in each type of setting. The full set can be found on the CMS website. It's called the Care Item Set and B-Care. We included the links to specific tools for some settings. There are more of these tools on the website. In general, the detailed view has more information when you click on it by highlighting key points, which highlights key points about the resources website, which setting or settings it was piloted in, with links to some of the tools they've developed. And some provide an estimated completion time. Not all tools are listed on the overview of the website that we have listed here, and you may find additional resources by visiting the website when you click on it. Next slide, please. The Health Equity in Readmission Guide is another example. This one contains recommendations and tools that focus on reducing readmissions among diverse populations. Although it was piloted in inpatient and outpatient settings, the resources and tools can be used or modified for any setting. There are links to guides about reducing disparities in healthcare to help reduce readmissions and improve care. We hope that you will use this toolkit to search for tools as you develop not only your care transition and coordination plans, but to improve overall health, reduce disparities, and decrease hospital readmissions so you can continue the journey to population health management as we move toward value-based care. So now that you know where to look for resources, I'll go through the steps of implementing a care coordination plan in your facility. Next slide, please. So these next several slides will help you plan for and build your own care coordination plans. Next slide. So this is an overview of the key components of in a quality improvement model. The next few slides will dive deeper into each step. First, engaging stakeholders and building a team. Second, clearly articulating your goals or aims. Third, performing a gap analysis on where you are now and where you would like to be. Fourth, testing the performance of the changes you've implemented. And finally, spreading and sustaining those changes so that they're locked in. Next slide, please. So here's the first step in creating your care coordination plan, and that will be to build your team and engage your key partners. As with any major project, it's important to have an executive sponsor. Next, choose your clinical leader and frontline staff who drive the care. Obviously, these two are very important. If you don't have a sponsor, you really don't have a program. The clinical leads and the frontline staff are those that are so much impacted by your plans. Next, include someone from your resident council or patient advisor and add subject matter experts in care coordination. And this is a great time when you develop your team to think about which external partners will benefit your plan to help you be successful. External partners could include even local public health, small practices, large practices, and behavioral health centers. Next slide, please. So after you've established your team, you'll work together to clearly articulate your goals and aims. You all need a common vision. Creating SMART goals is a great way to ensure that you're setting goals that are attainable and that you will be able to sustain. The SMART goals, as you probably know, are specific, measurable, actionable, realistic, and have a timeline. Next slide. Conducting a gap analysis of your current and ideal state and assessing your current workflow for care coordination and comparing that to your desired or ideal state will help your team identify where your areas of opportunity are and in turn help you to inform the actions in your SMART goals. Using the resources provided in the compendium will help you to develop your gap analysis. There are a lot of helpful tools and resources to bring you to your ideal state. And it will help to develop your action plans and accountability for that plan. It's important to engage all staff, identify gaps, and defining workflow as an iterative process using CQI, continuous quality improvement. And of course, involve all your staff to garner those fresh ideas. Next slide, please. So this is probably familiar, but using the PDSA, Plan, Do, Study, Act cycle, you will test the strategies you've implemented into your care coordination plan. Developing a plan, implementing it, studying the effects, and then acting on any modifications that should be made will help you achieve your desired goals. As with any project, once you've reached the desired goal, don't forget to celebrate. Next slide. And we've used the Lewin theory here to show that it's important to unfreeze, change, and refreeze when you do a change. As so it's important to spread and sustain your progress using the models like the Lewin's change model. That's a great way to spread and sustain your care coordination plan. Following the steps listed, you'll have unfrozen and begin to implement the change within your team. So you determine what needs to change, ensure that you have strong support from management continuously, create the need and the common vision, and manage your understand the concerns and doubts that your members have and that your whole staff has, in fact. See, you will then want to communicate often with all staff about the changes made. Communicate often, dispel rumors, empower through action, and involve the people in the processes. And then finally, refreezing your new plan by anchoring it into the culture of your facility and celebrating your success. Develop the ways to sustain the change, provide support and training, and again, celebrating the successes. Thank you all for your attention today. I'm happy to answer any further questions that you may have during our Q&A session. But first, I'll turn it back over to Jerry to go over some brief polling questions.
Thank you, Lisa. That was a great presentation. So we'd like to hear some feedback from you. And we're going to enter we're going to start with our first polling question. Kelsey, if you want to pull that up, and it's, do you believe your organization will utilize this resource that we've shared today? We'll give you a few minutes to answer there. Few minutes, I mean a few seconds. We'll give you a minute to answer. When people are like,
yeah. And I think, as one of the things Lisa pointed out, the really nice thing with this tool is that it's very adaptable. So if there's something specific that you're looking for, that you're struggling with as it relates, to care coordination or care transitions, I think the variety of resources that Lisa provided gives you the ability to kind of sift through that and look for, how do I address problem X or problem Y? And so you don't necessarily need to use every single resource from A to Z, but it's nice to have that full slate of tools available at your disposal. So as Lisa mentioned, you really don't have to reinvent what you're doing or building, because a lot of this has already been developed.
I think that's a great point, Kelsey. It's not really just even one tool, it's a resource to connect you with other tools.
And then just as a reminder, Kelsey did post the link to the tool for Care Transition Resource. Superior Health Quality Alliance resource tool for care coordination is listed on the chat. And our website is also listed under there. So I think one way to, we could have just done a demo of that tool, but I think you can go into the website, look at it yourself, and move on, go through some of the tools.
So it's look like, and I think we can share the results. It looks like everybody who's going to answer is answered. Can everyone see the results? So of those who did answer, 88% said yes, that they would use the tool, and then just 13% said no. And there is no wrong answer, so thank you. And then Kelsey, if you want to share the next polling question. This one has got a few, and what we're looking for is, where is your organization at with planning or implementing care coordination? Are you thinking about it? Are you just getting started? Have you implemented at least one method or tool for care coordination? You've got care coordination fully implemented, but it needs work, or you did not do, you do care coordination very well in your organization. So again, we'll give you about a minute or so here to answer. And I think it's just really helpful to figure out where everybody is in this process. And I think the resource that Lisa has shared with the resources in it, is helpful no matter what stage you're at.
And I think to that point too, Jerry, even if folks are at a variety of different stages with what care coordination looks like in their facility, there's always room for change or improvement. I mean, maybe you're doing something, but it's not working very well. And so just to sort of reiterate, what Lisa shared, I think can be helpful for you to just get some ideas about what this could look like, how we might be able to do this differently. Maybe, yes, we are doing it, but, it's not quite right. And so that PDSA cycle will really be helpful for testing out something new. I think, as part of global quality improvement, right? We never set out with, we know the answer, this is what needs to be done. We think we do, we try it, we see what happens, and maybe it works great, maybe not. But that's sort of where that iterative cycle comes in of just try something. There's no right or wrong way. Maybe it works great and you just need some minor tweaks. Maybe it's a colossal failure. If so, you've learned something and you can kind of move on from there.
Looks like we're not getting any. I think everybody again who's answered is going to answer. I'll share the results here. Hopefully everybody can see the results. So looks like we have 13% who are just getting started of those who answered. A quarter of you have implemented at least one method. And then we've got 50% who have fully implemented care coordination, but it needs work. And then we've got 13% or one who does care coordination very well. And I'd love to hear from actually everybody who answered the question. If you want to put anything in chat, especially those who are, have implemented, but they feel like it needs work. And it'd be really interesting to hear from the ones who are doing it very well, if they'd like to share some of those things in chat, or you can take yourself off mute, that are working well, or what you've done to implement care coordination in your organizations. I'm gonna take those off there. And that really kind of leads into our last question, which is really something we're looking for you to put into chat. The answer here is, what additional education or resources would you like to see? And as an example, a deeper dive into this.
Jerry,
I'm sorry,
share?
Lisa.
Do you want to share the results of the last poll, please?
Oh, I thought I did. I'm so sorry. They went away now for me.
Oh, could I share it? I can share it.
There you go.
Oh, there.
I thought I had shared them. Thank you, Lisa. I did not know I did not share them. So yeah, here's the results from the last. I was just reading them off, so but everybody can see them. It's probably a little easier than, okay.
And we might want to back up, do we want to discuss now on this, what's working for people, what's not working for people, before we go on to the next question? Or
I think that's a good point. Yeah, go ahead, Lisa.
Yeah, so let's just have people chime in. What is working? What's working really well for you in your organization? If you're doing a really pretty good job, we'd like to know what you do to help make that job easier, just to help others.
And again, if you want to take yourself off mute and just share, that's great. Or else, if you're more comfortable, you can just put your answer in chat, because I agree with Lisa. It'd be great to hear from those who are doing care coordination, what's working well. And also from those who are struggling, what it is that you need help with. And you guys will have to let me know if you see anything in chat, because I'm not seeing chat right now. And just if there's anything else too, I know it's kind of, again, the question we have up there, but if you are struggling, or if there's, you put care coordination in place, but there's things you need, what is it that you need? What can we help you with to improve the care coordination in your facility? What other tools would be helpful to you?
Or barriers, what is it that, if you feel like you're doing a pretty good job, but yet somebody's coming back in, or, do you hear anything, feedback from your patients, their families, on what you could have done better?
And kind of on that same point, is there something that you would like to see done better, maybe, someone's transitioning back from the hospital, or when you receive a new resident who maybe had home care before, is there tools that you think would be helpful for you to be able to provide to those organizations to help with care transitions, things, or different ways you could communicate with them that we could help you in that way?
And it always seems that people can always find what's wrong in the other organization. So what's not coming from the hospital, that you would like to see coming from the hospital. You guys are the ones receiving the care from the hospital. What are you not getting from them? Or maybe you're getting everything you need. And, we won't belabor this. If you do think of things, just go ahead and put them in the chat.
I'm going to take the poll down now, Lisa, if that's okay.
Yep.
Oops. And I think we've already kind of mentioned this, but again, and if you think of something later on as we're talking, please feel free to put that in chat too. But also any other educational resources that you think would be helpful. And also, if you think of it even after the session today, click on, we'll put the evaluation link in later, but that is another place where you can, I thought of this is what I'd like to get more education on related to today's topic, or, this is what I'd like to see from the hospital when I get one of my residents back from the hospital. So, you can use that form too, if you, think of it after our session today. I don't want you to think that didn't answer today that you don't have a chance to still give us that feedback. So we wanted to do a little bit of follow-up from our session last week. So I don't know if there were any other questions related to today's session other than what we just put up there for polling questions. Any other questions that people might have related to today's topic, or even if they're not related to today's topic, any questions that you have?
Yeah, I had a quick question for Lisa. Thanks for that presentation. That was great information. I liked the recommendation of involving so many different team members in creating a care coordination plan. And I know you mentioned the role of an executive sponsor. I was just wondering if you could kind of go into more of like what that role is, who's usually in that role, that kind of a thing.
Oh, yeah, great question. And basically it's your organization's leadership, so that they're behind. It's hard to implement something without leadership support. So really, it starts, if you have an idea, you want to bring it to leadership and say, what can we do? Can we have the staff for this? What is the budgeting for this? Making sure that you have the budget, the time, the staff. Well, the past couple of years has been really challenging for every organization, but especially nursing homes who are already challenged with staffing levels. But something that's as important as avoiding readmissions and avoiding harms to patient, the leadership should be all over this with support, but it really is getting that okay from the leadership and really nailing it down to what is budgeted, what time do we need, what kind of regular meetings are we going to be having, when can we meet, where can we meet, all the details of getting that executive sponsorship involved, and it's leadership.
Great, thank you.
And thank you, Julie. That was a great question. I'm just wondering too, for those on the call, looking at the team members that Lisa mentioned during her presentation to, pull this group together for care transition, knowing what everyone has had to go through in the last 2 years with COVID, is that something, how has that worked, or how is that something that's maybe had to fall to the wayside during these last 2 years? I'm just wondering, with care coordination, knowing that you probably have had more, residents, coming in and out of your facilities, how has that worked over in relationship to COVID? Is that something that's been a struggle, of course, or is it helped you put a better care coordination plan in place? And I know we had people who answered that they're doing care coordination well, or just have to tweak some components. So it'd be really great to hear from those of you who are doing care coordination. What have you found to work best for you in your facilities? It'd be great to hear from you. Again, chat, or if you just want to take yourself off mute.
Hi, this is Kim. Something that really worked well for us with care coordination in regards to the residents or short-term care people coming to us from our acute care hospitals was our relationship, of course, with them, but we used liaisons. We had people that worked for us that would really form, oh my gosh, just incredible relationships with the hospitals that were sending the residents to us. And we didn't always have that. And once we implemented that strategy, our workflow between the two parties really, our communication improved, the processes improved. I just can't emphasize how much, I mean, yes, maybe we all can't afford to hire hospital liaisons. I understand that, but simple communication, improvement of, and meeting with those entities that you do business with on a daily, not daily, oh my God, that'd be crazy, wouldn't it? But on a regular basis would really, really helped our care transitions.
That's a great point, Kim. I'd be interested to know if anyone on the call today does have those liaisons, and I'll have to, just from my previous life, I actually worked as a liaison in a hospital, but more for our home care agencies. And I agree with you, Kim. You know, if you can afford to have that, have someone in there who meets with the family or the patients before they go home and is there making sure everything is in place before they, you know, go back to your facility, it is a great asset. So I'd be interested if anybody else does use liaisons on the call today. And you can just put it in chat if you do or don't, and if you found it helpful.
I'll speak to that just a little bit in a managed care perspective. And, you know, for the number of years I've been in healthcare, the liaisons were used in the 80s and 90s, you know, a little more, it seemed like. And then it got to be expensive with DRG, you know, people just didn't want to afford, you know, pay that staff person to be the liaison. And it seems like people went away from their use a little bit, but now with managed care, everybody is going to get hit financially if that liaison or a coordinator is not utilized. And now it seems like it's coming back again, care coordination, coordinator, a liaison, whatever you want to call it, it will actually help prevent rehospitalizations and prevent excessive costs by using and paying for those. And so you can actually pay for that by having no hits for your payments, your Medicare payments.
It's a great point, Lisa. Are there any other questions anyone has or comments or anything that you'd like to share about how you do care coordination in your facilities? If there's not anything else right now, you know, Kelsey and I wanted to just kind of do some follow-up from last week. And again, if something comes up, feel free to put it in chat or let us know. You can certainly still talk about it. So we did just want to talk a little bit about this year's flu season. I think everybody's probably heard that, you know, flu cases are up. It seems like that's all I hear on the national news. Of course, part of this is probably due to, you know, that in the last 2 years, a lot more people have been, you know, masking and not getting together as much, you know, due to COVID. But, you know, now that people are out and about more, we are seeing a lot more flu cases. And I think I'd heard this morning too that, you know, flu deaths are up and probably compared to what we've had the last 2 years, are much higher than what we've had in the last 2 years already, and we're only in December. So as you can see here, there is a lot of flu out there. There is more than one group of flu viruses that are spreading this season. But so far, the laboratory data it's showing that the vaccination that we have for this year with the seasons, that we're getting a good response from that. So that, it looks like the flu vaccine for this year so far is covering those flu viruses that are out there, and that we should have a good effect from it. But that said, though, too, fewer people have gotten vaccinated against the flu. Don't know if it's just, I know a lot of you have had, your residents vaccinated, but that doesn't mean that the people coming in to visit, or even too, how many of your staff have been vaccinated. So we're seeing that the data is showing that a lot of people have not gotten vaccinated against the flu. So as a healthcare professional, it is a strong recommendation, and it's a critical factor for both your residents and the patients you serve to get an influenza vaccine every year to not only care for yourself, but your patients and your family, and protect everyone. And this is from the CDC, and it's just a way of looking. It's kind of it's called SHARE, just a way of looking at the information of how to share about the flu vaccine. And you want to make sure that you share why the flu vaccine is right for the resident, given their age, their health status, their lifestyle, and then, for your staff, their occupation, and any other risk factors they have. So, letting them know why you think it's important that they get the flu vaccine. You want to highlight experiences with flu vaccines. It could be personal or from your facility as appropriate, to reinforce the benefits of the flu vaccine. And this also helps create confidence in the influenza vaccination. Address the questions that your residents or their families have about the influenza vaccine. What are the side effects? What's the safety and the effectiveness? As we said, this year, it looks like the vaccine is effective to those strains of the flu that are out there. And so a lot of this just, you can go to the CDC website to get this information. And a lot of times it's just sharing those facts with, families and residents so that they know why it's important. And again, you want to share it in understandable language with them. It's okay to acknowledge that a lot of people, I think we've always heard this, I got the flu vaccine and I still got sick. And the important thing about it is getting the flu vaccine may not help you. You still may get the flu, but you won't get as sick. And hopefully will not have to be hospitalized or protects you from, the other thing too, is we've heard a lot with the COVID vaccine protects you, people from dying. So again, while we can't always say you won't get sick, it's still going to help you, get a bad case of the flu. Make sure you remind your residents and families that it's also important to get the influenza vaccine, not only protect themselves, but to protect their families and their loved ones. It helps you protect you from spreading influenza. And for some people who don't have as good of immune response from the flu vaccine, you don't want to be spreading the flu to them. And then it's always important, you can share the potential, cost of getting the flu. So, I'll just share an example of my life. My husband has not got his flu vaccine yet, and he said he doesn't have time. And I'm like, and I just keep reminding him, he doesn't have time to be in the hospital either. He doesn't have time to take away from work, and and he doesn't want to infect his loved ones. And so I think sharing those kinds of things can help people to understand why it's important to get the flu vaccine. So those are just what I wanted to talk about with flu, and I'm going to turn it over to Kelsey now, follow up from a question we had last week.
Thanks, Jerry. And, it is interesting just to note about the vaccines and folks still getting sick. For those of you who have been joining these calls and have heard me speak in the past, this is not my normal voice. I have been fully vaccinated, but still have come down with something. Not sure what it is, so apologies, but definitely it's sort of another case example of why it's important to still maintain, social distancing, hand washing, despite being vaccinated, because aside from COVID and RSV and all the other flu and, everything that's going around, there's still other stuff circulating. So with that, I did, as Jerry mentioned, just want to follow up to a question that was asked last week regarding how well surgical masks compared to N95 work to sort of prevent the spread of COVID. I think it is interesting to note, and I'll review these 3 studies that are on the slide here in a little more detail, but there is a little bit of dichotomy between publications that found that N95s were in fact better than surgical masks and others that found that they were essentially equal. I think part of this and sort of what it boils down to as we look at these studies is to really look at the types of tests or trials that were done to make these determinations. So if this was a lab test or a population study, right, all of that really will play into kind of how these conclusions are drawn and maybe what those real world implications truly are. So the first study I'll touch on, this was published in June of 2021, and it was a meta-analysis study. So basically what they did was they aggregated a whole bunch of evidence from other studies, basically to form their position based on this whole conglomerate of data and evidence that had already been published. And so what they said is that basically they suggest that N95s are superior to surgical masks in the lab specifically, but that population studies didn't found a notable difference, meaning they were basically equivalent when we looked at practical applications. I think it's important to note there is a caveat here that this could be due to a lack of proper fit with an N95, right? Again, sort of reiterating why it is so critical for us to be doing the fit tests, because without that, right, we're getting gaps that we would otherwise see with our surgical masks. The other piece that they called out is that cloth masks definitely fall short when compared to either our surgical masks or N95s. That shouldn't be a surprise to anybody on this call, and this is certainly not a recommendation or an appropriate type of PPE for our healthcare settings. And I know that wasn't part of the question that was raised, but just wanted to kind of note that as well. And then this study also spoke very briefly about how surgical masks and N95s are intended to be single use and how some of the decontamination processes that we saw really commonly being used during the height of the pandemic did compromise both the mask integrity and the filtration efficiency. So a question as to how much of that difference between our N95s and our surgical masks could be due to some of the decontamination practices that were happening. Before I jump into the next 2 studies, I want to take a minute just to note, these study 2 and 3 talk about the filtering face piece masks, and they are filtering face piece masks are very similar to N95s. They are not identical, but they do have a lot of similarities, but also some differences. I'm not going to talk about the details of what's alike and what's different. But I think it's just important for us to kind of keep that in mind as we look at these studies, because again, both of them use these FFP masks, not N95s, though because they're so similar, I think we can really extrapolate the results from what they found in the FFPs to our N95s. So our second study here came out of Princeton University in November of 2021, and they highlighted that face masks significantly reduce the risk of infection, even if it doesn't fit perfectly on the wearer's face. I think really the big conclusion from this is that the fitted filtering face piece masks, when fitted appropriately, can reduce the risk of infection by 2.5 times compared to a surgical mask. They also go on to say that these filtering face piece masks should be preferred to a surgical mask. The last study was also published last November 2021, and this one came out of the Cambridge University Hospital, and similarly found that filtering face piece respirators provide more effective protection compared to surgical masks for healthcare workers who are caring for COVID positive patients, regardless of whether or not aerosol generating procedures were undertaken. They called out specifically that using a surgical mask resulted in a 5-fold increase in infection. And then when switching to that filtering face piece respirator, the reduction was greater than 50%. So another really strong study that shows that these filtering face piece or N95 type masks are much more effective at preventing infection than when we look at surgical masks. Now, there is a study I want to touch on briefly that is not listed on this slide, but it's something that, you know, our team has talked a lot about, and I know there's been a lot of chatter in different public health and epidemiology and infectious disease groups about a recent randomized control study that came out of Canada just this, I think it was November, and it compared, again, our N95s to our surgical mask. And given the conclusions they drew and the way that the study was conducted, it's caused a lot of chaos because the science was not sound and the conclusions they drew were really not appropriate. So basically what this study did is they looked at 1,000 healthcare workers in Canada, Israel, Pakistan, and Egypt over a 2-year period. And so what they did basically is they assigned groups of healthcare workers to one of two groups, either a group that was wearing a surgical mask or a group that was wearing N95s, and they were 10-week study period. So for 10 weeks, you were assigned to one group or another and would then wear that mask. I think from a human subject standpoint, right, this is really problematic since we are knowingly potentially putting people at risk of contracting COVID by assigning them to use what we're speculating in this study is an inferior type of PPE, which would be our surgical mask. So I think the other issue here is that with this, the way that they set up the study, the folks who were assigned to the surgical mask group could just decide at any point they could wear an N95 and they could do it, right? So when we're doing a case control study, we want these two groups to be separate so that we can very clearly say, okay, this is our group that wore N95s, this is our group that wore the surgical mask, and compare those outcomes to each other. Now that we're getting some mixing and a group that's maybe dabbling in one and the other, these groups are not separate and distinct, which really is a critical component for this valid scientific research. So a number of issues related to the way the study was set up, obviously very flawed, and the conclusions they drew, basically what they said was there isn't a difference between these two types of masks, which for folks who didn't read the study in thorough detail and analyze the way that this study was conducted is problematic. When you just read that bottom line of N95s and surgical masks are equal, and taking that out of context, say, well, we don't need to wear N95s anymore if surgical masks do the same job. So you may or may not have seen that, but this has been a huge rift, if you will, in the public health and epidemiology community. And I think, you know, the only reason I share that is just to sort of give you guys the intel behind that in the event that you do hear that or see that, so that you can kind of tease apart what that research did, how they did it, and the reasons why looking at that conclusion they drew isn't really appropriate. So feel free, the links are here if you want some lovely nighttime reading, knock yourself out. But I think really moral of the story here is at the very worst, these two things are equal, but I think we have enough evidence to suggest that N95s, particularly for our aerosol generating procedures, are high risk. If we're caring for folks that are known COVID positive, that's going to be the absolute safest and best way to protect ourselves. Next slide, please. So for those of you who were on the call last week, this is the table I mentioned about time to infectivity depending on your mask selection. And I apologize, this might be really small on your screen. I've included the link at the bottom there, but I think it's really, really cool to see, like, if we start in the upper left-hand corner and we look at two people in a room who are not wearing anything, right, what the time is to infectivity. And there's 3 numbers in each box. The black is our like original alpha strain of COVID. The red is our Delta, and then the blue is Omicron. And so you'll see as we go from black to red to blue, this time gets much quicker. which is really in alignment with what we know about how infective these different variants are. And as we've moved away from that Alpha variant to our Omicron, they've become much more infectious. So we start with 10 minutes, we go to 4 minutes, and then for Omicron, we're under 2 minutes. Now, as we go across the top, this is what the vulnerable person or the healthy person is wearing. So from nothing to a cloth mask, surgical mask, a fitted surgical mask to N95, and then a fitted N95. And again, you can kind of see as you go across each row and each column, depending on what each person is wearing, how long it would take for the vulnerable person to be infected. All the way at the right and all the way at the bottom, you'll see what does this look like when both people are wearing a fitted N95. I'm just going to zoom in so I can read this, and I apologize, it's so small. So it looks like 1,667 hours time to infectivity with our wild, 667 hours to Delta, and then about 267 hours for Omicron. So obviously this is a huge jump from what we see for people, neither person wearing anything, where we're under 2 minutes for Omicron. Now we're like talking weeks in terms of hours for both people wearing an N95. So I think kind of two objectives or takeaways here. I think the first is just to show that wearing a better mask and a fitted mask can improve protection. And then with our more transmissible variants, certainly the combinations of masks that perhaps provided enough protection earlier may be less safe or less effective now. And really, as we look at this matrix is sort of intended to be a relative comparison of risks depending on the different combinations. So if without mask in a certain situation, we're looking at 10 minutes to infectivity, in the same situation, right? How would this time differ or lengthen if, say, someone was wearing a surgical mask and the other person was wearing an N95, right? So by sort of doing that combination and comparing it to the box in the upper left, which is effectively that control group, we can really see very clearly how N95s worn by both, worn fitted and effectively, right, can really help lengthen our time and keep us protected as long as possible. Obviously, I'm not suggesting you stay in an N95 all day and all night forever, but I just think this provides a really great picture of the importance and the benefit of good mask wearing and appropriate mask wearing depending on your situation. So I know I've thrown a lot at you. The resources are all there, but I'm happy to answer any questions you have about any of the things I've covered and about Jerry's slides as well. I think, Jerry, I'll put you on the spot and say if there are any questions about your slides that we can take those now too.
Yep, that's fine. Or if people have any other, if they've thought of any questions from Lisa's presentation earlier too. I think we've got just a couple minutes left here.
I'm going to drop the evaluation in the chat as well. If you can just take a couple minutes to do that before we sign off, we would appreciate it.
I don't think we had any other questions in chat, correct? I did. Just want to make sure I didn't miss anything. I just want to remind everybody that we do not have a session next week. As I said, we're moving to the twice a month schedule. Our next session, will be December 21st, 12 o'clock Central, 1 o'clock Eastern. And Kim or Kelsey, can you remind me our topic? Sorry, did not write it down before I started today for the 21st.
Yeah, sorry, Jerry. I just had to pull it up real quick.
I was gonna say, I know who the presenter is. I just don't know.
So we are going to be talking about sepsis tools linked to viral sepsis as it relates to COVID-19. And so we have another one of our sepsis experts from Superior Health that's going to come and talk about that. And I think it'll be a really great conversation to just highlight some of those tools and resources. And again, sort of that link back to COVID.
Great, thanks. And again, we appreciate your suggestions for topics too, because we are trying to get speakers for other topics that you have suggested. So anytime there's something else you want to hear about, just let us know. And you can also put that in on the evaluation link. There's not any other questions. Just remember, we also have Superior Health Connect, where you can, if you haven't already joined, please do, but there's a lot of great conversations going on, not just about COVID and the nursing home setting, but about chronic disease management, infection control, immunizations. So if you haven't already joined Connect, please do. Resources, the link to our care transition resource is linked here. And then also we have Lisa's contact information. Other than that, that's all for today. Thank you again for joining us. We'll see you all back here in 2 weeks. And stay safe till then.